Hi, my name's Sebastian Gutierrez-Olvera, and I want to talk to you today about celiac disease. So, here we actually have our Dr. Cody slide with our really long definition, perfect definition of what celiac disease actually is. In simple terms, however, it's almost like a severe gluten allergy. The presence of gluten in the intestinal tract ends up triggering the formation of antibodies that are a bit too reactive and are catastrophic to your ability to digest things. So, part of the mucosa of your intestinal tract has villi, and their purpose is to increase the amount of surface area so that chemical reactions can happen faster and it's easier to absorb things, as well as some of the other functions that villi have. What the antibodies end up doing is they end up destroying the villi by flattening them out, inflaming them, and so they no longer serve the purpose that they were originally intended to hold. Now, this is catastrophic for a couple different reasons that I'll get into pretty soon here, but it is one of those things where we want to talk about right now how it's inherited, because that'll be later as well. So there are two mutations that are very prevalent amongst celiacs, and that's HLA-DQ2 and DQ8. They're just variants on the same gene. They're both in chromosome 6, which we'll talk about that pretty soon to come. So let's talk about the symptoms really fast. So we have these three main ones. We have our gastrointestinal damage, and it's mainly intestinal, which then will lead a little bit into that malabsorption. And then I'm going to talk really fast about this dermatitis herpetiformis, which we have a photo of up here in the top right. So that is also known as gluten rashes. We see them in about 15% of celiac disease patients. They kind of form at common areas like joints such as elbows, knees. Other areas are the buttocks and the scalp. And so it's actually caused by the same antibody that we talked about earlier. Just ends up traveling and causing more damage here in different areas of the body. So moving back to our to the intestine and the damage that we cause it. So that antibody ends up preventing any function and inflaming the area. So we see that erosion of the villi, where instead of being like little fingers, it ends up getting fatter and clumping together, thus destroying the surface area. And that surface area is important because that's how we absorb things. It helps us have faster chemical reactions with the nutrients that we're trying to pull in. So that leads to the malabsorption. Once we have our inflamed villi, we can't pull as much as we used to. And so malabsorption and this chronic inflammation end up comboing together to make further complications that I'll talk about here in a second. And so furthermore, here's that second. We're going to talk about the complications that come from malnutrition and that inflammation. So we have that chronic inflammation, right? So if you're constantly eating gluten, right? So every day you have a sandwich, even though you have celiac disease, and you get some of that gluten content, the protein gluten, you're going to see those hallmarks of inflammation that we talked about earlier in the immunology course, right? So it's going to be pain, swelling, and heat. So your stomach's just going to be uncomfortable as an immune response starts to ramp up in there. The swelling is actually severe enough to where it's one of the diagnosis tools for little kids. If you have a child, they eat something with gluten in it, and you see a pot belly, that is a telltale sign that you should probably go get them checked out to make sure that they don't have celiac disease. And if they do, you can start taking care of it. But furthermore, if our villi are unable to do their job, we have the malnutrition. And the malnutrition will lead into further things. There's osteoporosis, rickets, osteomalacia, and other bone problems, development problems end up coming from this as well. 'Cause if you're a little kid and you have celiac disease and you can't pull the nutrients from the food that you're eating, you are unable to grow. There are a bunch of issues that'll start stemming from that. Ataxia, for example, is clumsiness, right? You're unable to fulfill the needs of your body to function well, and it starts to seep into your everyday life with everything that you're doing. Along with that, there's just no demands of nutrients that you're able to meet while you're in that inflamed state and you have that damage done to your stomach mucosa. So it's important that if you're feeling all of this discomfort after you eat anything with gluten in it, that you go get checked out. So we're going to talk about diagnosing now. So we've touched on some of the things that celiac disease actually ends up doing, and we can try and figure out different ways of diagnosing it. So the first thing that's going to happen if you suspect that you or your child has celiac disease, you're going to speak to your primary care provider. They're going to tell you that you should continue eating gluten. And this is for the sole purpose of just making sure that any of the tests that you end up performing are going to actually be the result of eating gluten. So the first thing that ends up happening is a blood test. They're going to be checking your blood for those antibodies that we talked about earlier that erode that villi. And so if they do see that level of antibody, they might ask you to sign up for a biopsy procedure. And so what would end up happening is it's not rectal, it's going to be through the mouth. I forget the official terminology. Through the mouth, they're going to end up endoscopy, and they're going to take a small section of your stomach lining. And so here I have the two photos of a healthy biopsy of somebody's intestine, and then that of a celiac disease patient who has been eating gluten. And you can kind of see the villi, exactly what we're talking about. The villi are damaged, they're blunted, eroded, and fattened. And this is the result of that antibody doing its thing. And then further, we'll have further blood tests if things are still inconclusive at that point, or just for the sake of tripling down. They're going to be checking for deficiencies. They're looking for that malnutrition. This will also help with diagnosing, prescribing you certain treatments after the diagnosis. They want to make sure, what are the things that you're not being able to absorb? Can we supplement them? Those types of things. And then there's been further pushback or push forward, I guess, to start including genetic testing, especially because if we see 97% of patients have that DQ2 or DQ8 gene, we should be looking for that as a way of just confirming outright whether a patient has celiac disease or not. But that's all the diagnosis thing. Let's talk about those who are actually going to be at risk for it. So unfortunately for those of the fairer sex, it's more prevalent in them, more than twice as much. So the numbers break down to around 17.4% per 100,000 women end up having celiac disease, while in their male counterparts, we saw 7.4% per 100,000. Along with that, we also see higher rates in people with already inherited chromosomal disorders. So trisomy 21, Turner syndrome, which is interesting because those genes that I mentioned earlier, DQ2 and DQ8, aren't on those chromosomes, even though trisomy 21 Down syndrome was explicitly mentioned primarily and quite often throughout some of the literature. Different chromosomes. So that leads into some of the theories on why people end up actually developing celiac disease, where people believe it's environmental factors. such as stress or your gut microbiota. Um, Along with that, along with the chromosome disorders, we also see higher rates inside of those from Northern European descent. So all those the white folk from Norway down to France, I believe, end up seeing those higher rates of celiac disease. And then if you're also directly related to somebody that has celiac disease, and you'll even see it in mothers, no one in their life has celiac disease. They have a child, the child ends up developing it, they see the pot belly, go get the child checked out, and then now their percent chance of developing celiac disease jumps to that 10% because it is lying dormant. Um, so now that we've talked about who's at risk, let's talk a little bit about how we can treat it. So now we're here. You have celiac disease, you've confirmed it, you saw the symptoms, you got diagnosed, you were in the risky population. Now what? So the first thing that you want to end up actually doing is going on a gluten-free diet for the rest of your life. It's a little bit harder than you think it might be. You have to avoid all of the ingredients that actually contain gluten. But if you're able to do that, you're going to be very, very thankful, as you won't end up destroying your stomach and your intestine. Along with that, since we've been experiencing that malnutrition and malabsorption, there's going to probably be supplements that you end up getting recommended to take, such as iron, right? One of the big things that we end up seeing is that iron deficiency, which is why anemia is actually one of the further complications of celiac disease. If you end up actually having that dermatitis herpetiformis, you're going to get a particular prescription for a cream to rub on that area to reduce swelling, reduce the rash, and whatnot. And along with that, you might be prescribed corticosteroids just to help with the inflammation. And you're going to constantly want to go and check in with the doctors and just make sure that everything that you've been doing is up to date, you're taking care of yourself well, and that gluten-free lifestyle is actually being very helpful for you. Because we actually want patients with celiac disease to have as high quality of life as they can. So if they're actually able to pull off that gluten-free lifestyle, which is not as bad, especially when you consider the alternative being those gastrointestinal problems, the stomach pain, bloated stomach, gas, constipation, diarrhea, fatty stools, the anemia, which is the yellowing of the skin that we saw, just all the fruits of the malabsorption that we saw earlier coming to full fruition. You can completely cut that stuff out because most of the damage, around 95%, I believe, of the damage done by celiac disease is actually undoable, which is very, very positive news for those that prolong the amount of time before they actually get medical help with celiac disease. There's a lot of really good hope for it. There are, however, unfortunately, for around 5% of people, complications that arise with constant refractory celiac disease where they just can't get rid of it. It's unfortunate for those in those situation, and so they're really going to be wanting to make sure that they're constantly getting that medical support. And then if you actually end up leaving it untreated, life is just going to be very, very uncomfortable because quite a lot of food ends up actually having gluten in it. And with that, I want to say thank you for watching, and I hope you learned something.